Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Happy New Year, everyone! I hope your 2020 is off to a great start. I had a very busy last few weeks. As some of you know, I was traveling to Santiago, Chile. I was in Texas for the San Antonio Breast Cancer Symposium. And then I got to head back to Chicago to visit family. I also held a little meet and greet and had a couple of dinners and meetups with some breast cancer survivors and thrivers and caregivers who were in the Chicagoland area. A huge shout out to Andrea and Miranda. It was great. This week's theme is on genetics. We sent out an announcement today in our newsletter that I want to share with you as well in case you missed it. Well, first of all, if you're not already subscribed to our newsletter, please hop over to survivingbreastcancer.org to join our mailing list. In the newsletter we sent out today, we sent it out every Monday actually, and today, with all things being new and exciting in the start of the new year, I am pleased to share that our organization, survivingbreastcancer.org, will be conducting its first research project. Specifically, we are taking a close look at the ethical implications associated with genetic testing as it relates to breast cancer, the diagnosis, as well as a predisposition. If you're interested in participating, shoot me an email at laura@survivingbreastcancer.org and we can chat more. In today's episode, we have a few special guests on the show. Be sure to listen until the end to meet one of our volunteers, Maddie Subhanyagam, who asked some pointed questions to help us understand the role culture plays in genetics. But first, we have a genetics counselor, Fatima Amir, with us. Fatima and I met at a BPREP workshop taking place at Dana-Farber. BPREP stands for Breast Cancer Personalized Risk Assessment, Education, and Prevention. It's a program which helps high-risk individuals understand their chances of developing breast cancer and guides them through strategies, lifestyle changes, and risk management to decrease their chances of developing breast cancer in the future. Part of the workshop involved an educational session led by Fatima where she discusses the opportunities for genetic counseling and testing and why we may want to consider scheduling that appointment. Today, Fatima and I discuss the BRCA 1 and 2 gene mutation, the importance of knowing your family history, understanding the statistics, and what lifetime risk actually means. Plus, we take a deep dive into understanding our genes, the future of genetics with the advent of artificial intelligence, and so much more. Fatima received her MS in medical genetics from the University of Cincinnati and Cincinnati Children's Hospital. She joined the Center for Cancer Genetics and Prevention at Dana-Farber Cancer Institute in 2018. She provides genetic counseling services to adult patients across a wide range of specialties. Fatima has a special interest in providing culturally competent care and in improving access to genetic counseling services among diverse groups. Fatima is interested in community medicine and sees patients at the Dana-Farber Community Cancer Center at the Whittier Street Health Center. Welcome to today's conversation.
I'm so excited to be part of this conversation, and I think it's nice to kind of get the voice out of also from the genetic counseling perspective. I think not a lot of people know genetic counselors exist. I think partially because genetic testing is something that has only in recent years started to become more and more commonplace in the whole healthcare model. And so I think it's exciting for me to be able to talk about what we do.
Today, you're actually one of our first genetic counselors actually on our show also. So this is a first for us.
Oh, that's exciting.
And survivingbreastcancer.org, who's like the nonprofit of which this podcast comes out of, is a pretty young organization as well. And so we started this maybe about 2.5 years ago when I was diagnosed with breast cancer. And I've coined this term of it's an SBC first, because every month, every day, there was something new that hasn't happened yet.
Right.
So this is one of those SBC first moments of having a genetic counselor on the podcast. So
absolutely.
I'm really excited about that.
Yeah, I'm very excited to be part of it too. So Thank you for having me.
I had an opportunity to come to Dana-Farber and participate in a series that I think is coined B-Prep?
Yeah, B-Prep. Yep. Yeah. They hold a symposium, I believe, annually, where they have kind of a series of different talks. And one of the things they have also is a genetics kind of workshop, so kind of a breakout session where we can learn about genetic testing and who should be getting genetic testing. And so, yeah, that's where, you attended the workshop. So I was really happy that we connected afterwards. I was happy to talk about genetic testing. Yeah, we absolutely have a lot of communication, I feel like, between the genetics department and a lot of the other oncology groups, because at the end of the day, lots of those groups are the ones that are referring people out to us, to genetics, and so definitely lots of great kind of multidisciplinary care that we aim for and we serve. So.
Absolutely. But I do understand that it was geared towards those who do not have breast cancer, but potentially have a lesion or some sort of higher disposition to potentially developing breast cancer.
Absolutely. A lot of the women who are followed in B-Prep, to my understanding, are people who have something about their, so something like, for example, something called ADH or atypical ductal hyperplasia, something like that can increase their risk of potentially developing breast cancer. So oftentimes that might not actually necessarily be a hereditary predisposition, but sometimes, people do end up coming through the B-Prep clinic that there's something about their family history or their personal history that might raise a flag or two about, should this person potentially be considering getting genetic testing? And that's when some people get channeled over our direction to come meet with a genetic counselor to talk about the option of genetic testing, to kind of explore that a little bit more.
Yeah, and I think that really lays the framework for this conversation too, because there's so many different populations of people who are interested in genetics testing, or honestly, I never heard about it really until my own diagnosis. I mean, I've seen the ads on TV for Ancestry or 23andMe or the more commercial side of this new opportunity to learn more about ourselves. Yeah. But not so much in a proactive way of in terms of disease and diagnosis or predisposition to, it doesn't have to be cancer. It could be, any type of diabetes or other type of hereditary family concerns. And then I have a whole population also, which I know are some of our listeners, are those who have been diagnosed with breast cancer already and have now gone through genetic testing and they are sitting on information. And I think that's another piece of the navigation of, one, is it an option for me now to get genetic testing? Should I do it? Yes or no? Right. And then kind of that labyrinth of, okay, if I do it, how do the results come back? How do I interpret them?
What's that whole process?
I mean, I have more. I can spend this whole hour asking questions. So let me just stop there because that's, I think, super informative just to kind of shed light on what genetics is.
Exactly. So that's a good, and one thing I feel like sometimes I like to step back in my sessions that I have with my patients and just remind them that when we think about kind of, if we put everyone kind of in this pie chart of all the people who develop cancer, only about 5 to 10% of those people will actually be identified to carry a genetic mutation upon doing genetic testing for them, based on kind of the figures we have right now. So the vast majority of cancer is typically just what we call sporadic, meaning it just kind of happens. Sometimes it can be due to some kind of, lifestyle factors or environmental exposures, but oftentimes it can also just be because nature isn't perfect. And we talked about this in our little workshop too, where, sometimes just our cells can create an error in the replication process and form into a cancerous cell. But what we're doing in genetics is trying to identify with genetic testing whether or not someone falls within that 5 to 10% category of people who do actually carry a mutation or a change in one of their genes that increases their risk to develop cancer over the general population. Because there is benefit in knowing that in terms of not just, sometimes it can be helpful for the actual patient themselves if they have a cancer diagnosis for themselves. In some cases, it can actually help guide some treatment decisions. But oftentimes it's also really helpful information for family members. So I think you brought up a good point about there's this element of genetic testing where we hear about it a lot in the media in so many different forms. One thing I think from a breast cancer perspective, I feel like that shed a lot of light on kind of breast cancer genetics was the whole Angelina Jolie situation where she was found to have a BRCA, and I am not that up to date with pop culture, so I can't remember if she had a
Either am I.
BRCA1 or 2 mutation, but she had one of the BRCA, mutations.
Yes.
And, I remember we still have this term called the Angelina Jolie effect, where a lot of people, that was their exposure to knowing that they could potentially have been born with a hereditary predisposition for cancer, and that they should, might want to consider genetic testing to help guide their care.
Absolutely. And about your statistics that you were just mentioning,
yes.
So between 5 and 10%
Mm-hmm.
Show predisposition through family history or hereditary genetics.
Exactly.
And is that for the general population of just cancer, or is that specific to breast cancer?
So that's a good question. It can be generalized to all cancer as well, but specifically for breast cancer, those numbers probably look the same as well.
Mm-hmm.
Between cancer types, that number can look a little different. So one of the things we see it a little bit higher for example, is ovarian cancer. Mm-hmm. So that's why anyone with an ovarian cancer diagnosis, typically here we're testing all of our ovarian cancer patients, or recommend testing for them. They automatically do meet criteria. Like there's this national criteria that we sometimes follow of who should be meeting criteria to get BRCA 1 and 2 testing. And so anyone with an ovarian cancer diagnosis should be getting that, because 20% of ovarian cancer can be hereditary.
Okay.
So we can
higher
identify.
than that.
Exactly.
Okay.
It's a little bit larger than that 5 to 10%.
Interesting.
Mm-hmm.
And vice versa then, if you've been diagnosed with breast cancer,
Mm-hmm.
do you have a higher risk potentially then for the ovarian cancer?
So that's a great question.
Kind of intertwined.
Yeah, so the breast and ovarian cancer, oftentimes people, they can be linked. And the reason that they're often linked, I think, in our minds is because the main breast cancer hereditary genes that we know of, BRCA1 and 2, which actually, fun fact, BRCA was for breast cancer, so that's how the genes were named.
Oh my gosh.
Yeah,
that is
so
a fun fact.
yeah, exactly. So with the BRCA1 and 2 genes, the main risk obviously associated with them is for female breast cancer, but the second largest risk is for ovarian cancer. So that's one of those genes where you see an increased risk for both of those things. There are other ways in which those, having, for example, your ovaries removed can potentially reduce the risk of breast cancer. Now, that's not obviously a one-size-fits-all statement. You also don't want to be recommending people get their ovaries removed unnecessarily. It's also important not to undergo menopause, unnaturally earlier, since that can also have its other kind of effects. But, there's definitely a link there in terms of, with the BRCA1 and 2 genes, there's an increased risk for both of those things. So that's why they're often linked.
Absolutely.
Mm-hmm.
And it's something we hear about and talk about a lot in our
Mm-hmm.
breast cancer community. And we've done stories in other podcasts talking with women
Mm-hmm.
about how do you navigate even that decision of your body had just been through so much with a breast cancer diagnosis. Right. Now you're carrying a gene. Are you
Right.
considering a full hysterectomy?
Right.
And we've been fortunate enough to hear all sides of the story.
Yeah.
And it's not black and white.
Yeah.
And there's a lot of vetting and, just I think having these conversations
Absolutely.
to come to terms with it, right?
Absolutely. And I think one of the things, so with the BRCA1 and 2 genes, for example, the hysterectomy, typically with the BRCA1 gene, it's a little bit earlier, the age that we recommend someone meet with their gynecologic oncologist to talk about the option of the hysterectomy. So it's, they say past childbearing age, quote unquote, but really what they're saying is past 35 to 40 is that age range they quote by national guidelines. And then there is, for the BRCA2 gene, 40 to 45 is where we start having that conversation. So, we also know that the risk for ovarian cancer, when we're quoting the risks associated with the BRCA1 and 2 genes, oftentimes we're quoting lifetime risks. So
Yes.
that risk number can look pretty high, but really if you broke down the risk and look at models that show you the risk by age, it's actually much smaller over those 5-year intervals potentially. So sometimes I've oftentimes pulled up the risk model we might use for that to show people okay, even if you carry this gene mutation, this is why we're not recommending you remove your ovaries immediately, because really the risk
Right.
is very, very low in the next 5 years for you to develop ovarian cancer, for example. So it's absolutely fine to wait till, the age that we would recommend removing it. And I think, speaking of removing parts, ovarian cancer, obviously, because it's just one of those cancers, unfortunately, that doesn't have a really solid form of screening that we know of that works. That's why there is that recommendation to remove the ovaries. But with breast cancer risk, it's a little bit different. So even though there is a high risk for breast cancer for individuals who have a mutation in the BRCA1 or 2 genes, it's not it's not absolutely necessary for them to have to remove their breast. So that's something that I feel like with the Angelina Jolie effect, she chose to have a prophylactic bilateral mastectomy, meaning she removed her breast tissue. So a lot of people had then this concept of, if I carry a mutation, does that mean I have to remove my breasts? And that's not true. One of the things that, there's also the alternative option to that, which is to just have high-risk screening. So that's where you're getting not just annual mammograms, but also annual breast MRIs. And the data shows that the survival rates are the same between the two, which means they're both good options. So there's really no difference there. It really just comes down to, I like to tell my patients, obviously they will meet with their, surgical oncologist to figure out, or their oncologist to make the actual decision so they can go into the nuances of it. But from, just from a general kind of perspective, the way I like to put it is it really just comes down to a person-to-person choice. With the surgical removal of the breasts, it's what we would call a risk reduction surgery. So you're reducing the risk of a new breast cancer by removing the breast tissue. But with the screening, we're really just trying to go for early detection. So you're not necessarily reducing the risk of a new breast cancer, but you are increasing the chance of detecting something at an earlier stage, which can really change the outcome.
Yeah, you brought up so many phenomenal points right there. I'm so excited. So you mentioned lifetime risk. I think that's a really critical point to kind of hone in on a little bit more.
Yes.
And with regards, again, to these statistics, because that's a lot of what people have been asking. They want to understand, what my risk is. And I think the moment you say a number, they do come into this, myself included, fight or flight, right?
Absolutely.
I carry a gene, I need them removed tomorrow, put me in surgery.
Exactly.
So, and you're saying, not necessarily, let's look at the data and the long-term lifetime risk.
Absolutely.
So I'm kind of picturing that, exponential scale,
Right. What I usually use in my clinics is something called the Ask to Me model. So there's a website we can go on to typically that I'll pull up with some of my patients often, and you kind of enter the age that someone is and what gene they have a mutation in, and then it can kind of not just make some of those graphs kind of like you described, but also put these tables out in these 5-year intervals, what is kind of the risk that exists potentially.
Sure.
Now, obviously, it has the limitations of it being a model, and there are things about a family history that could potentially be changing some of these risks too. But it does give, I think, a really nice layout and a visual kind of representation for a lot of people of that. Even if we're quoting a lifetime risk, say of 20% or 40%, whatever that risk might be, we're not saying that that's the risk every single day, right? That's a lifetime risk over lifetime studies that have been done. But the actual risk within the next 5 years for people your age is this tiny number right here. Mm-hmm. So I feel like that does definitely help people feel a lot better about their, that their risks aren't maybe as high as they might be perceiving it to be.
And it gives them some time to do their research
Exactly.
as well.
And I think it can definitely help put people at ease too, ease their mind a little bit as well. And, like you said, I think sometimes there is that mindset of, I need to just take everything out right now, I need to be doing something about this, or, sometimes that feeling can occur understandably. And so that I think kind of rationally puts things into perspective that, this is not something that is as high as your risk perception is right now. It's still a relatively low risk, and we need to look at the pros and cons of, removing your ovaries at such a young age might not be a good idea because it can affect your bone health and other things as well. So we want to make sure you get as closer to the natural age of menopause as possible before, making a decision like that.
Absolutely. And speaking of risk then, right? So now we assess the lifetime potential.
Right.
And then the different types of, if you're high risk, then the opportunity for more screenings, more regular screenings.
Right.
I was talking to a woman once, and I don't know if every hospital, or again, going back to standards and guidelines, is like this, but she was saying she was getting screened every 6 months. So to what you were saying, 1 year would be the mammography, and then the second year, or within that year, 6 months later, it would be the MRI. So they were staggered. So she felt very confident every 6 months having some sort of test.
Absolutely.
Just to monitor her.
Absolutely. And I think that's where it goes down to is, I've met people who are very adamant on, that they don't want to remove their breast tissue, that they would feel much more comfortable, have much more peace of mind with the screening route. But I've had the complete opposite too, where people come in saying, no, I just want to go ahead with that option. I know I'll do that if I do test positive. And, I think that's where it comes down to every person has a different story of what different level of comfort with what they're comfortable with. But, the good thing is that we do have those options, particularly with breast cancer risk. We know both of those things are really good options. And so that's definitely, I think, reassuring in some ways.
And then there's a whole handful of us who have finished active treatment, and we're like, please screen me, please screen me.
Right.
And like, you don't need the MRI, you'll be fine.
Right, exactly.
So, yeah, you definitely have the full spectrum.
Absolutely,
yeah.
absolutely.
And so along the topics of, screening, you can meet with patients, whether if it's a family history, and to do a panel of genetic testing, as well as if you have been diagnosed with breast cancer. A couple of questions along this topic. One thing that really sparked an interest during your workshop was the number of genes you could be tested for. Yeah. And I'll just stop right there.
Yeah.
I think I personally was tested for probably the top 8, specifically for breast cancer, for a breast cancer panel.
Right.
And I think you mentioned somewhere upwards of 70, I want to say.
Yeah, so the largest panel that we are typically offering can be anywhere between 81 to 84 genes, depending on what lab we're going with. And yeah, I think that's a really good thing that you bring up is, there's definitely, over time, our approach to testing has changed a lot. So, back in the day, probably 10 years ago, if someone had a breast cancer diagnosis and was recommended to get genetic testing, at the time, they were likely only being tested for just the BRCA1 and BRCA2 genes. Over the years, as technology has evolved and as we've learned about more genes, and I think as, genetics just becoming more commonplace within the kind of the healthcare model as it is, I think now more and more people are starting to be comfortable with offering kind of the larger panel. So here I can speak specifically to what we do typically. Oftentimes here we are kind of we cast a wider net is kind of how I like to explain it. So, even if someone is coming in mainly concerned about their breast cancer risk in the family, oftentimes we'll still offer a panel of what we might call a common hereditary cancer type panel. So what that typically is comprehensive for are genes associated with not just breast cancer risk, but also gynecologic cancer risk, which often those genes go hand in hand oftentimes. But then also gastrointestinal cancer risk that includes things like colon cancer. And the reason we're kind of casting that wide net for these kind of cancer risks is because oftentimes, even if it's unexpected that we identify someone has, let's say, a moderate risk for increased risk for colon cancer, for example, our thought is we'd rather know that information than not know it because it could actually change someone's management. So we might say, you know what, instead of waiting till 50, like the general population, to do your colonoscopies, you might want to start at 40 and maybe go every 5 years instead of doing a 10-year plan, for example. So if there's something solid that we can tell people, and if it could potentially be helpful information for their family members, I think that's one of the reasons we've moved to, doing panel testing, because, even though it's rare, there have absolutely been times where we have seen a family that does not look like your textbook example of what we might think of for the mutation that we actually end up identifying. And I think that actually is a good segue into talking about the fact that there's lots of limitations with family history oftentimes. So that's something that, we as genetic counselors also trained to look at, some of those gaps there in the family history. So sometimes, one limitation in family history provided is sometimes people just have a really small family. So if you have a small family, there's not a lot of people in the family that, you're going to see cancer diagnosis in because there's not a lot of people, or people died at young ages. And so, who knows if they lived a little bit longer, what kind of cancer diagnoses we may have seen. But then also, sometimes there's families where there's lots of males, not a lot of females. So you might not be seeing a lot of breast and ovarian cancer in the family because guess what? There weren't a lot of females in the family. So things like that. Or, another big thing is that cancer historically was something, and even to this day, there's some communities where people don't talk about cancer diagnoses. They don't share their diagnoses with family members. So people might not know of cancer diagnoses in the family. And I think because family history is in nature, imperfect in that way, our thought is we should at least cast that wide net for the genes that we know that potentially there could be something that could be done about it. Now, there's always a caveat where some genes in there, we might not be able to change some screening with some of the risks associated with it, but generally speaking, for the most part, there might be something we could do differently, and so I thought I'd rather look at that than not look at it.
Right.
But at the same time, we meet the patient, at their level, what they're comfortable with. There's definitely been times where I've definitely scaled back and done smaller tests, because sometimes, especially, if you've had a new diagnosis, you don't want to think about anything else right now. Right now you just want to know what you need to know for making your surgical decision or whatever it might be. And that's absolutely fine. And that's, I think one of the big benefits of meeting with someone like a genetic counselor is they're going to help you make your decision in terms of what's the right decision for you. And it's not a one size fits all. So
absolutely. And I think you bring up such great points yet again about the different cultures and how we can, again, provide education, and that's part of the prevention piece too. I know for me, we're going around, we have a speakers bureau, we're doing events and we're sharing information to empower people to ask the right questions. Right. And one of the things I tell people is go home and ask your mom or your dad, get your family history.
Right.
Because I don't know, it's not talked about.
Absolutely.
You don't know about it. And then, I just have a running Word document now of okay, these are all the things I have to worry about.
Absolutely. I mean,
it's something that's simple that you can proactively do and then just keep on file.
Exactly. And, that reminds me of, one of the things I hear so commonly in clinic is, because oftentimes before we see a lot of our patients, we send them a family history questionnaire. So that gives them the time before they meet with us to actually be able to fill out, the details of their family, and it allows them to give time to ask, those exact questions like you were mentioning to their family members. And so many people come into the clinic and they say, I didn't know about some of these things until I asked. Right. And so that's, just goes back to, I think it is absolutely important to, kind of be aware of your family history. And at the same time, there's lots of cancer is sporadic and it's not something that's hereditary. So oftentimes I feel like people come in who might say, oh my gosh, there's so much cancer on this side of the family, or I'm always worried about this, but I can sometimes be even reassuring to them as, what, this type of cancer is most of the time sporadic. It's not something we'd be worried about. And so sometimes even just that's helpful to hear for people.
Exactly. So speaking of relationships that patients develop with you as a genetic counselor, so they come in and you help navigate, the panel and what's going to be tested, either specifically for breast cancer, or you cast a wider net. How often should patients then follow up with you for additional testing?
That's a great question. So in all the letters that we usually send out after, when we're sending out the patient's results and kind of after we've talked to them and stuff, in the letter, we always typically include a little line there that says, testing technology and stuff can always evolve. And so, it's possible that there will be more updated forms of testing that would be recommended down the road. So similar to how, 10 years ago when people were being just tested for BRCA 1 and 2, and now we know that there are other genes associated with breast cancer risk. So there are people who are coming in now for updated testing that wouldn't have been, their mutation might not have been captured on the previous test, for example, so because they weren't testing for that specific gene. So similarly, or our technologies just evolve. Sometimes our technologies can't pick up certain types of mutations at one specific time that they might in the future. So absolutely, we typically say maybe every 1 to 2 years or periodically, kind of, sometimes some genetic counselors may say, put me in your Outlook calendar, every maybe 2 years or so, and, just reach out to me and I'll let you know at that point if there's any kind of updated testing you need to do.
Oh, excellent. Okay. And what are some of the technologies that you're referencing?
So that's a good question. So historically, so one of the things actually that's probably more recent is, and this hasn't become standard yet, but let's say, for example, that right now, historically, a lot of the DNA testing that was happening was on DNA. So what we'd be looking at is the kind of, if we kind of, and just so we can actually, explain what all these terms are. So if you think about kind of our bodies as, there's lots and lots of cells that build up our bodies. And each of these cells, you can kind of think about, there's lots of genetic information that's kind of like a code book of, telling gives a set of instructions to tell the cell how to grow, how to function, how to develop. You can think of the genetic information in your cells as being kind of like an instruction manual. So in your instruction manual, there's a bunch of chapters, and in each of those chapters, there's a bunch of words that make up those chapters. Those words you can think of as being genes. And just how words are made up of letters, that's how genes are made up of DNA letters. They actually really do look like letters, when we spell them out typically in the code. But so what we're typically looking at with genetic testing is seeing, are any of those words misspelled, or are any of those genes misspelled? We all have the cancer genes that we talk about, like BRCA1 and BRCA2, for example. We all have these cancer genes. And the typical function of the genes, when they're working normally, when they're spelled normally, is to actually protect the cell from developing into a cancerous cell. But what we're looking at with the genetic testing is seeing, was someone born with one of those genes or one copy of their gene maybe being misspelled? That increased their risk then over the general population to develop whatever type of cancer is associated with it. So, a lot of the testing, even till today, what kind of the clinical standard is to do DNA testing. So that's looking just at, the little letters that are spelled out there. You can think of these instructions kind of like recipes that build an actual food product, or what you can consider like a protein. And the protein physically goes and does the jobs within the cell. But there's a middle step there before the DNA actually forms the protein. It's called something called RNA. So now one lab in particular has actually started doing RNA analysis in addition to the DNA testing. And so what they're doing is, with the RNA analysis, it's basically an added level of analysis, and the technology, of course, is a little different too. And it has the potential to identify changes that the DNA testing itself alone might not be able to identify. And the reason I don't know how many technical details we need to go into, but one of the reasons being is because when we look at our DNA, there's large stretches of parts within those individual genes or those words that, don't actually code for the protein, that we didn't really know too much about. So it's hard to really interpret what the meaning of some of those parts are. But what we can see sometimes is, so the DNA testing typically won't look at that part. There's because it's lots of stretch, it's unnecessary to have the technology try to go over a lot of that too. So it's typically just looking at the pieces that we know what they make sense of and what kind of code for the proteins. But what we're sometimes seeing is, DNA testing might not show us any spelling errors, but then when we're testing the RNA, it looks a little wonky. Mm-hmm. And so we're like, why does this look wonky? And then lo and behold, there's that some part in that middle part of the DNA that we didn't look at that actually has an error in there that allows for the RNA not to be built correctly, for example. So, as it's a little bit of a complex kind of way to kind of explain it, but that's what RNA analysis potentially could evolve into. So it's still very, very new. The lab that has started it only just started it this year, and so we're still in the process. The lab is in the process of gathering data on how often they predict that this is going to actually identify a change that DNA testing can't. But it's possible that something like this could become then the standard in the future. And at that point, we might have people coming back to get testing with the RNA analysis as well, because we already do know, at least of one case I'm aware of, that there was a something that was identified based on the RNA analysis in the BRCA1 gene that the DNA testing did not pick up. Wow. So it's a possibility theoretically, and we've seen it happen. So it's, who knows how much more it's going to happen.
If I'm understanding correctly too, it almost sounds like in the RNA process, is providing that that key of I caught something, like a double check.
Exactly. So it's definitely helped a lot. And the other thing it's also helped with is, with anybody who's had genetic testing might know that there's actually 3 possible results you can get with genetic testing.
Oh, I was going to ask.
Right.
So I actually am a recipient of that.
Right.
Which is a great question too.
Yeah.
Also with all the different screenings, and maybe this will be part of your answer as well, because I'm very curious, especially at this day and age, with the role of artificial intelligence and how that is infiltrating in terms of just screenings in general.
Yeah.
So that's just I'll talk about it because it's super exciting.
Right.
But you're going into all the great science detail. I think what we're really great about doing on Breast Cancer Conversations is having this conversation, doing the analogies, talking about the food, the letters, the DNA.
Right, exactly.
That's what people can relate to. So I'm sure we can do that with the AI conversation.
Exactly.
So I was overwhelmed with the breast cancer diagnosis, immediately went in for the genetic testing, chose a smaller panel because I wanted to focus just on the potential genes, high-risk genes.
Right.
And also for the people that are listening too, it's not just necessarily BRCA1 and BRCA2.
Exactly.
There are, and I probably can't name them all the way you can, but I know there's like HELB and ATM.
Exactly.
And check,
Yep. There you go.
So there's a whole list,
Yep.
and I'll definitely link to them in like the descriptions if people want like
Right.
more information.
Mm-hmm.
But I got this letter back,
Mm-hmm.
and it said that I had a variant of unknown significance.
Right.
And I'm like, I just got diagnosed with breast cancer, and my results are already coming back gray.
Mm-hmm.
Like, I just want information.
Solid. Yep. Yeah, and so that's something we always talk about in our genetic counseling sessions as well, is there's 3 types of results you can get back. So the 1 and 2 are kind of easier to understand, right? A positive result, meaning, yes, we identified a change in one of these genes we know is harming the gene's function, and therefore, what would we typically say? Yep, we'll come back in and we'll talk more detail about what that gene change is. The second type of result, just the opposite, negative. We didn't identify any harmful changes. It looks like the genes are working just the way we would expect them to. The third type of result is exactly that variant of unknown or uncertain significance, VUS for short. And really what that basically is a fancy way to say maybe or inconclusive. And what that really is saying is that the lab identified a change in one of these genes, so a spelling change in one of these genes, that they just don't have enough evidence right now at this time to classify definitively as it being a harmful change or a completely normal benign change, not changing anything differently, because we know that there's lots of normal changes in our DNA. So as you can imagine, we're all human, we all have human DNA, but there's lots of normal variants in our DNA that just make us different from one another, but it doesn't actually have any harmful, effects. And so we actually, the way we usually will talk to our patients about those variants of unknown significance, when we're talking about our kind of pre-test counseling, I always say we do not worry about these types of results for the most part, because we know that 90% of them, when the lab learns more about them and are reclassified to a negative, because there's lots of normal variation in our DNA. A lot of them end up being chalked out to that. Now, there is very few cases where, that 10% probably that does get actually upgraded, where they do learn more about it and it can actually be a truly harmful mutation. But because the vast majority of them are not, we typically kind of treat them as innocent and so proven guilty. And down the road, if the lab ever learns more about them, they let us know and we let you, the patient know. But I will also add that, all the reports typically have a description of what evidence they do have presently for that specific change or that variant of unknown significance. Yes. And I always go over that description before I call out results to my patients. So what I'll typically do is kind of look over that, and really that sometimes can give me a better sense of, I'm not at all really concerned about that. And very rarely I'll be like, that does look a little bit fishy to me. So sometimes I'll run it by the larger group. And very rarely we've actually treated some of those uncertain significance results as a positive result. Okay. We actually, there's been, one incident I know of where there's been a variant of unknown significance treated for the longest time as a positive by someone in our group. And lo and behold, many, many years later, it did get upgraded to a likely pathogenic mutation. So I think that just, hones in on the point of sometimes it can be helpful as a genetics provider to really look, critically at what that change might be.
Absolutely. You have your standard, and then you have your guts. Right?
Exactly. And what information we know, and maybe it's probably safer to, given the family history, given this, that we might treat this as a positive.
Which leads me to my next question. So if you have, whether or not you have this variant of unknown significance, sometimes people are asked then to go back to their family members and ask for additional testing to help paint this larger picture. Yeah. And that can also be very tenuous, right? We're talking about some of these ethical issues or dialogues that aren't always easy conversations to have. Absolutely. Can you speak a little bit about that?
Absolutely. So family communication is a big thing, right? That can come up, and sometimes it's something where I know, at least for our patients, sometimes so kind of speaking to, why even have someone else get tested in the family? Oftentimes that's because, the person who got the testing might not have been the best person in the family to get the testing, or there might be someone else who could give us a clearer picture. So for example, if we're testing someone who, let's say there's a family that has a lot of breast cancer in the family, and, people in the family who've had the breast cancer diagnosis themselves have not been tested, but someone who hasn't had breast cancer is curious about their risk. risk to know whether or not they have an increased risk, and they go ahead with the genetic testing. Now, if that person who does not have breast cancer tests negative, meaning they didn't identify any changes, there's a little bit of a limitation there where we don't know that they tested negative because the breast cancer in the family is not due to a hereditary cause, or that they just didn't inherit the gene change that could be explaining some of that family history. So that's where sometimes there's other people in the family we recommend get the testing, to help clarify the risk in the family. And sometimes if the person who has the cancer of concern tests negative, we might not even recommend anyone else in the family getting testing. So it depends kind of family to family, of course. But oftentimes, like you mentioned, the family communication thing is a big thing that can come up. And so sometimes what I'll offer to do for patients is write a family letter, kind of a generic letter that I can type up so they don't have to worry about having to have all the details or anything like that there. But I can write a generic kind of letter and then send it to a patient, and then they can kind of forward it and edit it as they please to customize it, send it to their relatives, so they don't have to worry about having that conversation or anything like that.
Yeah, it's very hard.
It is.
We navigated that with my family personally, and just really trying to understand that genetics is bigger than the individual.
Absolutely.
And trying to say, yes, we want you to get tested, and I know you don't want to know the results, but your results could impact my treatment plan, my surgery choices,
right,
and that sort. And that was hard.
There
was anger. There was
absolutely.
It was, it resolved itself.
Yeah.
In the sense that, for me personally, I came to peace with the situation.
Yeah.
And I was able to do enough research to learn about the surgery options to then just be comfortable regardless of what the result was going to be that we never actually tested for.
Right.
I knew what my surgery options were going to be, and me and my oncological team felt very confident in that.
Right.
So you're right. You have this team of people that you just talk through and
right. And
meditate on it a little bit.
Absolutely. And I think that's like you said, I think everybody comes in with their different story, whether it's their personal kind of journey with their own diagnosis, or whether it's their family history. And I think not everyone feels comfortable going forward with the testing, and they have their own reasons to. Sometimes, people don't want to feel, just want to, sometimes people cope with this information by distancing themselves from the information altogether. So people cope differently, and we see that sometimes often is that, obviously we have an ascertainment bias for who's coming through our doors, or people who generally are people who want to do the genetic testing. Right. But we do say that, there's no harm in meeting with a genetic counselor and not going with it. They're informational consulting. Exactly. Sometimes I'll tell people, even if you're not comfortable, going forward with the testing, we can walk through with this process, and you can make your informed decision at the end of the session. But sometimes one of the other ways we'll sometimes go over it is, I think there's so many misconceptions out there also about genetics and having a genetic mutation. So one thing, for example, I like to also hammer home is having a mutation in a gene does not absolutely mean that you're going to develop cancer.
Right.
So this is not
risk, right?
Exactly. Taking the example of BRCA 1 and 2, having a BRCA 1 and 2 mutation, the lifetime risk is estimated to be anywhere between 50 to 85% lifetime risk of breast cancer compared to the general population's risk of 12%. So it's a significant risk. But that also means that there's a 15 to 50% chance that you're going to have a BRCA 1 and 2 mutation and not develop breast cancer in your lifetime. Right. So, there's very few genes that have a near 100% lifetime risk. And so, having a gene mutation does not mean you're going to get cancer. And sometimes people have either had a personal journey where they've seen someone in their family undergo cancer diagnosis, and that's been really hard for them. So for them, they don't want to come to terms or even come to face the thought of potentially finding out about an information that could, tell them that maybe they have an increased risk of cancer because they've had, a really difficult time seeing a loved one go through something. And so there's lots of things that can factor into why people make that decision. But, one way to sometimes go about it is, let's say there is someone in the family who's really motivated to, want to have that conversation about genetic testing. Sometimes I say, if it's an option, maybe you can bring in your relative with you for your session as your support person, and then they can be exposed to the conversation, and maybe if they have some misinformation that can be kind of clarified, through the session, they have the opportunity to ask questions as well. And then sometimes maybe that's something that can, help them feel more comfortable with making whatever the right decision is for them.
Sure, absolutely. So this topic of, family history, not having like an individual response to it, it's like kind of larger than ourselves. Yeah. And tying this back into the technology with artificial intelligence and the more information that we're receiving, so when I got genetically tested, it literally was just a blood test. So for people who, we're talking about DNA and RNA and all these new technologies, but literally it was, here, go get your blood work done, drop it off, and you'll get results in 2 weeks. It was painless, it was easy, it was like just giving blood for anything else. But then, so I just envision, not having ever walked into like any of these labs, just like some big huge database with all these like letters and sequencing, and it keeps growing and growing and growing the more information that gets put into that database.
And so that's a good thing. So one of the things that comes to mind, one of the words that comes to mind when we're thinking about genetic testing, like from that standpoint, is big data, right? So lots of big data is being generated when you're sequencing someone's, genes and stuff. And now, disclaimer, I don't work in that kind of side of things too often, but, certainly the really talented people who are working in the labs and stuff where, there's definitely pipelines in process of how they kind of go from the raw data of like actually having these really huge files coming out of the sequencing, machines and stuff like that, and then how do they translate that into something that, where they can narrow down all these regular variants that are also being picked up, and just zooming into, okay, what are the actual potential variants here that are actually harmful. So there's definitely a whole process that goes in there, and I think that's where what's beautiful about like just the evolution of genetics, that I think a lot of the evolution kind of goes hand in hand with the evolution in technology, and so those kind of two things have kind of worked nicely for one another as well.
Yes, no, I think there's a lot of positive outcomes coming from this.
Exactly.
One thing I want to be incredibly cognizant about too is in my own, experience talking and having conversations with people, the likelihood of who is the person that's most likely going to be getting the genetic testing in terms of like demographics and ethnicity. And as we're feeding this database with that person's data, how does that impact the population of people who are getting breast cancer and have higher risk just based on being Hispanic or African American or Asian?
Absolutely. So you bring a really great point, is with genetics, historically, a lot of the, when we think about kind of, when we're identifying whether or not someone has a harmful mutation or not, when we're comparing it to a reference, the reference is oftentimes mainly made up of Caucasian individuals. And so we talked about earlier that there's lots of normal variation in our DNA, and that kind of goes across, different ethnicities. And so we know that because the reference database is largely made up of a Caucasian individuals, there can be a little bit of a higher chance of getting back those variants of unknown significance for individuals who are not of Caucasian descent. So sometimes I'll kind of mention that in our sessions too, is that we don't worry about them. We're testing all these genes. There's a pretty decent chance we're going to get back some. We estimate we get about 30 to 40% of the times we get back one of those inconclusive type results. But, there's definitely, I think a lot that there's definitely, I know, initiatives out there that are trying to, diversify the reference databases we have. I know just recently I was at at a conference for the American Society of Human Genetics, and I know there I heard people talk about the All of Us research study.
Yes.
So you've probably heard of that. I think it's out of the NIH, if I'm not wrong. And I know that they have tried to recruit actively individuals of various underrepresented populations to try to, and part of, they do have genomics included in their kind of study as well. I know personally I was a participant of the All of Us research study, so I think it was like 6 or 7 tubes of blood. I can't remember. It was quite a number of tubes of blood that we donated, but I think this is like one step in the right direction, and I think there's definitely, more and more we're being cognizant of the fact that, we want to make sure as we're evolving with our technology and making, again, making our genetic testing even better, we want to make sure that it's better for everyone, and not just for select individuals. So that's 100%. Definitely something that we, I think, are trying to be more and more cognizant of.
And it's so reassuring to hear. I definitely am a proponent and want to get the word out there too, also through the podcast about all of us and how, that's what it's called, right? Yes, all of us.
Yes.
And how people can donate their blood and be contributing to this.
Absolutely.
And that in turn is also going to lead to like the up and coming technologies around precision medicine, being able to understand your specific genetics and then developing a chemotherapy or an immunotherapy drug to target that specifically. And so it's traveling fast. Like it's happening now.
Right, exactly.
Which is awesome.
Right.
These things are taking place right now and people have a very active way of making a difference, which I think is just so cool.
Absolutely.
So I have to ask too, because I'm super curious. So like if we're getting to a point where we're able to identify that you carry a particular gene, are there ever going to be an opportunity, or maybe it's happening now and I'm not aware of it, in terms of like, let's say I want to have a baby and I'm carrying the BRCA1 gene, is there a way that I will be able to remove or even do a test to see before I even give birth? Yeah, okay.
So that's it.
You know what I'm trying to ask.
Right, exactly. Like reproductive implications,
yes,
right? Like,
okay.
So with the BRCA, we know of something called pre-implantation genetic diagnosis is one of the technologies that has come about with the advent of genetic testing as well. And what that typically involves is, when it's going through, so let's say, like you said, like we know someone who has like a BRCA1 or BRCA2 mutation, for example, and if they're, this person is, thinking of having children, they can go through the IVF process and do something called PGD, for short, pre-implantation genetic diagnosis is the whole mouthful, where they can actually test the embryos for whether or not they carry the mutation and then only implant the embryos that do not carry the mutation. Wow. So that's one way that that's an option. I know we have a group at the Brigham who does reproductive genetics, and so you meet with the genetic counselor similarly. I mean, here I do just cancer genetic counseling, obviously, but there's other genetic counselors who work in things like reproductive genetics where you then meet with someone to talk about how that's whole done. If people do carrier testing, you may know that's kind of a different ball game, is knowing if there's any risk of potentially passing on a genetic condition to your child. But then obviously there's also then other options too, in terms of some people consider, let's say, having an egg donor or something like that. Now, as far as BRCA1 and 2 mutations, we're typically not testing children. So that's where some of the ethics come in and stuff, because it's an adult onset condition, meaning the risks don't really take place until someone's an adult. We typically don't recommend testing children and kind of leave it up to it being their autonomous choice to get testing when they're an adult. The only time it might be appropriate to test a child for a BRCA1 or 2 mutation that I can think of off the top of my head, particularly a BRCA2 mutation, is there's for someone who is a BRCA2 mutation carrier, and if their reproductive partner is also a BRCA2 mutation carrier, there's a 25% chance that their child will inherit both copies of the gene that carry the mutation on it, and then that child can have something called Fanconi anemia. So it's a little bit of a different syndrome, and that can have childhood onset implications. And so that's where you might consider testing a child as well. So, but not to go too off on tangents, but
not a tangent at all. I think that's like exactly where the conversation is.
Right.
Like these are all conversations that people are having. This is exactly as you're mentioning, like the contemporary conversations that are happening in the genetics field. And the more that we're hearing this, even though I'm taking notes over here of all of these like PDG and RNA, and don't worry guys, there'll be a blog about it and we'll write all these terms down. But I think this is empowering us to then ask the right questions and giving us a resource to say, hey, I heard of this thing and I'm, in my 30s, I still am considering having children. I'm about to consider going through chemotherapy to kill the cancer, but like, what are my options? I mean, that just opens the floodgates for opportunities and dialogue.
Absolutely, you're absolutely right. And I think with genetic testing, there's so many applications of it too. Like you mentioned earlier, it's not just what we call germline genetic testing, meaning where you meet with genetic counselors, see where you're born with any changes in any of these genes. So is there a change in all the cells of your body, basically? But then there's the tumor genetic testing, right? So like you mentioned earlier, where you're testing the actual cancerous cells to be able to target any treatments there. And then there's, obviously genetic testing and other aspects too, like the reproductive genetics implications there as well. And just so many applications. And I think it's just ever growing because the more and more we learn about how genetics can be implied in healthcare, I think the more we're learning about that.
Yeah, I feel like we're just now, I feel like this is like episode 1 of many.
Right.
Because we are just laying the foundation.
Right. I mean, it's just we're in the first 2 decades of having sequenced the whole genome. And I mean, I know what's kind of crazy to me sometimes, and that's why I just feel so honored to be able to work at a place like Dana-Farber. But I work with colleagues who have been offering genetic testing for BRCA 1 and 2 since the 90s, and I'm like, that is just pretty amazing. We were offering testing for this before the human genome was sequenced. Like, what?
Awesome.
So so definitely really cool.
Definitely changing a lot of lives.
Yeah.
So that's wonderful.
Yeah.
Excellent. And I guess in terms of next questions, I think you've answered a lot of our just initial questions about how to interact with a genetics counselor, when is it appropriate to follow up with them.
Yeah.
For all the people who I left in suspense about my inconclusive diagnosis.
Yes.
I remember, and it's so commonplace now to hear, BRCA, BRCA 1 and 2, it's, rolls off the tongue. But at the time, it was the first time I heard of it.
Yeah.
I don't think I ever looked back at that letter. I was just like, okay, there's some variants going on. There was the whole family ethics and, decision making and argumentation. And, there were so many other things happening that, fast forward 2 years, I'm like, oh, there was an inconclusive result. Let me go back and pull out that paperwork. Yeah. And it was on the BRCA2 gene. And now everything that I know about BRCA2, I'm like, how come I wasn't more concerned? I mean, I just didn't have time to be concerned.
Right. You just had so much on your plate that you didn't,
And you were saying too that even in that place it would be treated as a negative, or usually, depending on the bigger picture
mostly
of my own personal background and family history. But I did get a letter recently telling me that my particular sequence came back, I think it was 90th percentile, being classified as negative.
Okay.
So that was great news.
Yeah.
And I'm just sharing this also in terms of sharing the information about the follow-up care, right?
Right.
I didn't call my genetics counselor. She called me. There was a little a heartbeat panic moment of what? Because the caller ID. I'm like, that's the hospital. Why are they calling me?
Right.
I don't have an appointment. I didn't miss an appointment.
Right.
But they were delivering good news. And I think it's just staying in the database and staying up to date as the new technologies are coming out.
Absolutely. And so typically what a lot of the labs are doing is that they have kind of, like you said, kind of in their database almost of this list of these variants of unknown significance or these inconclusive type results that they know they have, and that they are they are basically every 6 months or so doing a review on potentially of seeing is there anything else out in the literature, is there any internal data they have to support to reclassify one way or the other some of these variants. And then as they do, then they typically, at least I know here, the lab will let us know. So they'll issue us an amended report, and then we then contact the patients to let them know. And typically we'll just send them a letter, which again, for the most part, they've been reclassified to a benign or likely benign result. And so we send those nice little letters that, even if this was something that was on your mind now, it definitely should not be because it was nothing.
Love it. Is there anything else that we did not ask or cover that you would like to share?
Yeah. So that's a good question. I think one thing that, is probably also worthwhile to mention is, when we think about going back to what I had mentioned earlier with the pie chart, and you have the 5 to 10% people who are identified to have a mutation, and then the vast majority of being sporadic, meaning we don't actually identify a mutation for them. There's also a little bit of a category there called familial, which means that we might see multiple people in a family that have, maybe breast cancer or some type of cancer in the family, but we haven't identified a genetic mutation for them, so maybe they were negative on genetic testing. Sometimes the reason we also have that multidisciplinary care model, it's not just genetic counselors you're seeing, but sometimes you'll also be seen then with the physician as well, who has background in genetics, is because we sometimes might still recommend that you get maybe some kind of high-risk screening based on your family history as well. So the way I like to explain it is your genetic testing results are not an end-all be-all. It's not just, we're not looking at that by itself in, isolation. We typically are looking at your genetic testing results in addition to your family history and your personal history to help guide your care. Because at the end of the day, there's, as we've talked about, I think that the constant evolution of genetics, there are limitations with genetic testing. So there can be genes we haven't discovered yet that could be associated with, say, breast cancer risk, for example, or our technology is evolving. So maybe our technology might pick up mutations in the future that they're not picking up right now. And so for these reasons, we don't ignore family history. We might still take that into account to change someone's care. So that's why I think it can be beneficial to just, whether it's your provider, if you've met with a genetic counselor or anyone, oftentimes hopefully you'll then be referred into the appropriate channel. If you still need any kind of different screening, that you might still get that even if you were negative.
Yes. And to conclude on that note, so I got this great call. It was negative.
Yes.
Likely benign. I got the letter in the mail. So I'm like, that's great news.
Right.
And then immediately was like, well, then why did I get cancer, right? So do you fall into, like, you're back to the sporadic, you don't have a reason anymore. But I think I say this all in good humor right now because it's genetics and it's evolving.
Absolutely.
And I think genetics testing was one of the first experiences I had when I came to realize that medicine's not a perfect science.
Yeah.
And it's really interdisciplinary and it's very unique per person.
Absolutely. You're absolutely right. And, that's what I say. I think, one of the things I remember that stood out to me when I was still in training in graduate school was, when we think, because we're also trained as genetic counselors to, from a psychosocial counseling perspective. So one of the things I remember that stood out to me at the time was, I think going before my training, I would have thought that, just a positive result is what's typically something that someone's upset by. But a negative result can be upsetting to some people too, because sometimes people need an explanation for why what happened to them happened to them. And sometimes not having that explanation can almost be more frustrating. And so, I think as human beings, and this is sometimes I say often to my patients as well, as human beings, sometimes we have the tendency to want to put a finger on something and have a crystal ball and say this is why this happened, or that this is and sometimes people, I like to remind people, don't blame yourself for having done something. If I just did this differently, if I just did differently, there's also a big percentage of cancer that happens because just nature isn't perfect. And our cells, exactly. You think about, when we talked about all that DNA in each of our cells, there's billions and billions of letters in each of our cells. And every time a cell's replicating, it has to copy all of those letters each time. So think about a Xerox machine. And if that's copying again and again and again, it's bound to make an error at some point. And so our cells are the same way. They can sometimes just make an error. And even though there are mechanisms in place to correct those errors, sometimes those mechanisms might not work properly. So that's where just nature isn't perfect, and sometimes these things happen. But we want to make sure that you are being taken care of well, and that you are, we're here kind of to help guide you if you're concerned about, do I have this risk I might have been born with? Do I have a lot of cancer in my family? Are there people at a young age being diagnosed with a certain type of cancer diagnosis or anything like that? If you meet with a genetic counselor or someone in genetics, our hope is that we are able to kind of help you understand what your risk is, if there is a risk based on family history, and that you're connected with the right channels to, if there's anything differently that we do from a screening standpoint.
On the podcast, people don't always see all the additional guests that we have in the room, but I do want to open things up. They have been very quiet during this podcast, which is unusual for William. I know his voice normally pipes up at some point.
I submitted mine through Maddie's, but why don't you introduce Maddie too?
Yeah, absolutely. So we're also here, we're so excited because we have another SBC first, where we have one of our volunteers and interns from UMass Boston, who is a graduate student here with us and part of our Surviving Breast Cancer team. So Maddie, it's all yours. So, again, I don't think that was thorough. What are you studying? How did you get involved?
So my name is Maddie, and I'm currently pursuing MSBA in UMass Boston. And why did I get involved? Well, I have personal experience, not personally with breast cancer, but with one of my very personal family members going through cancer itself, and that's how I got involved in like the Cancer Foundation. And I saw William at one of our fairs, and I was like, oh my God, this is such a great organization, and that's how I came about here. So I do have one question for you.
Yeah.
Was when you come across like many patients, right? What are some questions that you wish your patients asked you?
Ooh, that's a good question. That is a great question. That I wish they asked me. Ooh. Wow, you really got me in a rut here.
Well, it's hard too, because a lot of times we walk in and we don't know what genetics really is.
Right. So that's something that I know thankfully, I feel like a lot of patients are very upfront about. Some people just say, honestly, I don't even know why I'm here. And I love that. Oftentimes actually when I'm going into a session, before I explain what this looks like I go through your family history, we'll talk about genetic testing. If you want to do it, you can do it today. Then I say, but before we jump into all of that, what questions do you have that are pressing? And oftentimes that opens the door to whatever is the most pressing question for them. So I think if I had to answer your question, I would like my patients to ask me the biggest question that they have on their mind, so that we can answer that first at the beginning of the session, and then that's something that is not lingering on their mind or that they don't forget, because at the end of the day, we're here to kind of answer your questions and really guide you through the session. And so definitely, ask away all the questions that you have personally.
Okay. Another one is like, you touched on different cultures and, different ethnic groups that, our database is like not really inclusive of all of those. And for me personally, like approaching that conversation with my mother or my grandmother is extremely hard, because you're going to be like, why? We don't have a history of this. But, to be on the safer side, like it's always good to know.
Right.
How would you suggest, like, cultural differences? What kind of cultural differences do you see in your patients, and how would you suggest that your patients tackle them when they have this conversation with their family members?
That's a great question. So kind of speaking personally, actually, so my parents are of Pakistani background, and I feel like, I feel like I can kind of relate sometimes to some of, some immigrant communities where I feel like I've seen this come up as well, where a lot of times when we think about care, we're thinking about care from okay, I broke a bone, I need to go fix it, but not preventative care isn't necessarily a conversation that happens too often. And so I think one of, I know at least from our standpoint as healthcare providers in the field, one of the things that I'm personally passionate about is to do community outreach, to do, have these kind of educational conversations, these educational discussions in communities that so often, might not be accessing or might not be utilizing some of these services, and, really kind of, help educate them around these of why we do this and what the purpose of this is, to kind of and making it more accessible too, because I think that's another barrier to a lot of people of getting genetic testing, because it's just not something that's accessible to them. Right. We're sitting right now at Dana-Farber, where yes, you've got 19 genetic counselors right here to talk to you about genetic testing, but there's lots of places that don't have a genetic specialist, let alone a genetic counselor. And so I think that, making sure that as a healthcare provider, the thing I like to focus on is trying to see what steps can we take to make our services more accessible to everyone. As far as what advice I would give to someone in the family, I think it kind of ties into what we kind of talked about a little bit earlier too, which is that, sometimes if there is a little bit of a hesitation for people to want to even think about this or talk about this, sometimes it can be stemming from a place of where, they don't want to come to terms sometimes with just, if they have seen someone in the family go through something difficult, they don't want to think about even the possibility of this being something that could be hereditary, a risk that other, exactly, absolutely. So I think that that's something that, from, where it could be potentially helpful if there is someone in the family who is interested in this. See if you can have that person come along with you to one of these things. And I think, we just need from our end, we need more and more outreach events as well to kind of talk to different communities who might not be exposed to a lot of this information and really talk in a group setting about why someone might consider this, what are the benefits of doing this. And so I know here I just started this community outreach kind of little quality improvement group in our department, so we can try to do some of this outreach in different communities that so often don't hear or talk about genetic testing.
Okay.
Yeah.
Those are the questions I had.
Great.
What was your background? Where are you from originally?
Well, I am Indian, but I grew up in Singapore. So I did my undergrad with business administration and biochem. So that was my little bit of my history. But I've always been passionate about. Well, like I said, I did see someone go through cancer, and I think being educated and having information at hand is really good, because knowledge is power, and that kind of helps you kind of make your decisions every step of the way.
Absolutely.
And wait, I do actually have another question.
Yeah, go for it. Yeah.
Is there any such thing as too much information?
That's a great question. You really have all these really great questions.
I was thinking too, while you're thinking about the answer to that, with your background with MSBA, we're talking about big data and all this sequencing. I'm like, oh my God, this is perfect. This is
right. Right. So, I think too much information. So, one thing that you said is something we say and hear a lot in our sessions is the knowledge is power piece of thing, right? So, like we talked about, a lot of cancer is sporadic. We don't know some risk factors that people might have. Sometimes when someone is identified to carry, let's say, a BRCA 1 or 2 mutation, we might actually have more of a clearer idea of what their risk is. And so we can help guide their care appropriately. So definitely, that's the thing is knowledge can be very powerful. Now, is there too much information? I think that's where, when we talked about the different sized panels that we can do with genetic testing, some panels might be large enough to where there's lots of new genes on there or genes on there that even if we did identify changes, we might not change any management because there's no real management guidelines on them or something like that. And that's where, as a genetic counselor, I work with the patient to see, based on what their kind of, how they want to take this information. Are they the kind of person who are like, what, that kind of information doesn't bother me at all. I'll just put it, it'll be easy for me to put it on the back burner and not worry about it. Or are they someone who it will be too much information for them and they don't want to have to think about that? And that's where we can, it's not a one size fits all, but we really work with the patient to see what's the best decision for them.
The last question that I had was, how do you reach out to that underserved community to try to bring them in for either clinical trials or genetic testing?
So that's a great question. With the genetic testing piece of it, so I don't necessarily work with clinical trials, so I'm not too familiar with what recruitment strategies are there. But from a genetic testing standpoint, so one thing that I'm involved in, I know here at Dana-Farber we have a Community Cancer Care Center over at the Whittier Street Health Center. So that's a federally qualified health center, actually probably about 10 minutes away from here in Roxbury. So about 4 times a year, I go there along with a geneticist on our team. And there's also other people on staff there too, like a nurse and someone from research as well. We go there at the federally qualified healthcare center where they're typically used to coming in for their care anyway. And offering genetic counseling and genetic testing right there on site. And so far from what we've seen is that testing uptake is basically comparable to testing uptake here, which is encouraging to say the least. But at the same time, I think there's there's always going to be room for improvement, I think. So a lot of times the people that the patient population we're seeing there are people who might not, maybe coming in on a weekday is really hard for them. If they have hourly jobs and stuff, sometimes transport is an issue. So I think that's something I definitely think about a lot is, what are ways in which we can make genetic testing and such accessible to them, in a way that they're able to then actually make it to the appointment.
And do you chase after grants? Because a lot of these people don't have the economic wherewithal to pay for genetic testing? It's
That's
quite
a
expensive.
great question. So we know that some labs that we use we're really grateful for some of these labs that actually do have, say, policies where, if you have Mass Health, then you have zero out of pocket. So we don't have to worry about any kind of out of pocket cost to the patient in that case. A lot of the labs have very, very generous patient assistance programs where if you have, if you're, at a certain level, kind of over even the poverty line, sometimes there's something, it's a zero out of pocket cost, very generous information there as well. But we don't currently have any grants right now where we can, directly, right off the bat say, yep, we have got grant money for this. But, I think that's absolutely something that could be helpful too.
Fatima, thank you so much for a phenomenal conversation. This was amazing. I felt like our energy was just feeding off of each other, and we were just so excited to be talking about all things genetics. Thank you so much for sharing your wisdom and expertise and answering all of the questions that we have. So until next time. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. If you're looking for specific topics or would like to be a guest on our show, please feel free to reach out to me. My email is laura@survivingbreastcancer.org. Until next time, keep on thriving.